Hello everyone, we are M.E.D, our Managed Education for Diabetics. Our group consists of Jessica Gutierrez, Gerald Biando, Acuna-Brown, and Marcela Espinoza. M.E.D aims to empower the African American community in San Diego to live healthier and happier lives by following the path towards properly managed diabetes. Our vision is that the entire African American community of San Diego will have complete confidence within themselves to boldly tackle diabetes. Our main goal is to reduce the rate of diabetes-related death and disability within the African American population in North County, San Diego by lowering blood sugar. Thus, our priority population are African Americans with diabetes in North County, San Diego. Our null hypothesis is that there is no observed difference between the groups measuring blood sugar levels. Alternative hypothesis is that there is an observed difference in blood sugar levels between the measured groups. 1 year post-intervention, we hope the participants will be able to understand what tests are needed to monitor diabetes. That 1/3 of participants will have successfully lowered their blood sugar levels between the recommended levels of 80 to 115 milligrams per deciliters. That participants will be able to list at least 5 types of complications associated with diabetes. And that 75% of participants will have adopted or maintained their self-monitoring of diabetes successfully. In our evaluation, we questioned what percentage of participants in the intervention lower their blood sugar. Is there a difference in diabetes management between the experimental and comparison groups? Can the complication of diabetes be reduced using exercise, diet, and/or medications? And between the health checkups and management workshops, which is more effective for participants? Our conceptual model is based on the health belief model. The perceived susceptibility of diabetes complications and the perceived seriousness of diabetes complications will change the perceived threat of diabetes complications. Our healthcare will provide acute action which we will address our participants' lack of behavioral capability, self-efficacy, and self-management, which in turn will change the perceived threat of diabetes complications. All in all, we hope that this will change the perform desired behaviors within our participants, in which they will know how to check blood sugar, having accurate knowledge about diabetes, and being able to perform accurate and good diabetes self-management. Our primary outcome are improved diabetes management among participants, which can be measured by improved health at routine health checkups, and greater community awareness of diabetes, which is measured by how many people attend our workshops. Our secondary outcomes are doing proper diabetic testing etiquette, which can be observed from our participants' ability to properly test blood sugar in one of the workshops, and promoting a healthier lifestyle among participants, including physical fitness and eating a well-balanced meal, which is measured by questions on our survey about how many times a week do you exercise. Our health outcome, which is lower blood sugar, is measured by A1C levels, and increased physical fitness and eating well-balanced meals, which is measured by our self-reported survey. Our research design is a quasi-experimental time series design. Experimental group, which is group 1, receives regular diabetes health checkups and workshops. Workshops are the intervention. Our comparison group, group 2, will only receive regular diabetes health checkups, no workshops, or no intervention. Our sampling procedure is a quota non-probability sampling procedure. Our quota being African American diabetics who live in North County, San Diego. Our independent variables are race, which African Americans, residency in North County, San Diego, and attendance at health checkups. Race and residency are nominal variables. Attendance at health checkups can either be an ordinal or a nominal variable. Our dependent variables are the workshops that we host and a pre and post test. We will be using a 20-question self-reported survey and blood glucose readings as our measures. This will be distributed to all participants. All participants will be given a baseline glucose reading and a baseline survey, then a glucose reading and survey every 3 months for 9 months, and then a final glucose reading and survey a year post-intervention. We will have a bivariate analysis, with 3 findings that are focused on from our objectives and evaluation questions, which are as follows. Our objective of 1/3 of participants will have successfully lowered their blood sugar levels between the recommended levels of 80 to 115 milligrams per deciliters, and the following evaluation questions that, do you know what the following tests are, and how confident do you feel controlling your diabetes? In relation to blood sugar level comparisons, we found the levels are in the now readings and therefore are not implications of overall good or bad diabetes management. When we look at the primary tests needed to monitor diabetes, HbA1c, and the participants' understanding of it, we see the experimental group had a much better understanding of what this test is for after participating in our intervention, while the comparison group actually went lower compared to the beginning. This means that with the help of our informative workshops, we were able to increase the knowledge of what it takes to self-manage diabetes. With our main goal of trying to reduce diabetes-related death rates and making sure our participants can live in a successfully well-adopted or maintained self-monitoring of their diabetes, we find the results of their confidence in controlling their diabetes to be very important. With that, these results show again that most of the experimental group will be able to utilize their knowledge from this intervention to self-manage and control their diabetes. For our chi-square results table, we use this common count formula using the results from the initial numbers table. After computing each cell, we were able to sum up a significant level of 0.272, which does not fall between the significance levels of 0.05 and 0.01, thus finding that our program will fail to reject the null hypothesis and concur that there is no difference in blood sugar levels between the groups. The advantages of our program is that there is no control over outside sources. This increases external validity due to real-world conditions. Also, there is reduced contamination by sampling each group from 2 different locations in North County, San Diego. The limitations in our program, however, is that targeted population is limited to just African Americans in North County, causing a small sample size. There is also a lack of randomization, a self-reporting bias, and that both groups had adequate drops in blood sugar. Therefore, we cannot conclude that our workshops are a better treatment for type 2 diabetes than regular health checkups. This is a possible Hawthorne effect. So what do these findings mean? Well, over 50% of all participants lowered their blood sugar, in which over 1/3 of participants in both the experimental group and comparison group were able to lower their blood sugar. Thus, all of our objectives were met. The M.E.D program met all stated goals and objectives, ultimately benefiting the diabetic population of North County, San Diego through educational workshops and regular health checkups. Thank you.